Hello, I'm Natalie Johnson, Associate Director of Aspen Ideas Health. Thank you for joining us for today's session, which is a deep dive into the topic, the future of healthcare in a post-COVID world. We are very honored to welcome our distinguished panelists, Dr. Karen DeSalvo and Dr. Atul Gawande. Dr. Karen DeSalvo is Chief Health Officer at Google Health. She is a physician executive and works at the intersection of medicine, public health, and information technology. She was previously National Coordinator for Health Information Technology and Acting Assistant Health Secretary in the Obama administration, as well as the New Orleans Health Commissioner. Dr. Atul Gawande is a best-selling author, a surgeon at Brigham and Women's Hospital, and a professor at Harvard, where he founded Ariadne Labs and Lifebox. He also founded CIC Health, which scales up COVID-19 testing and vaccine distribution. He was previously CEO of the healthcare venture Haven and has been a staff writer for The New Yorker since 1998. Thanks to you both so much for being here today for this Aspen Ideas Health session. Over to you.
Well, great. Thank you, Natalie, so much, Atul. It's really good to see you.
Fantastic to see you, Karen.
I have a memory of a phone call with you many months ago. I was in a restaurant and we were having a call about something. And the reason that matters is because I have not been to a restaurant since the pandemic started. And so seeing you evokes a different world that I'm not yet ready to go back into, I think, in some ways, which is why the title of this session, The Future of Healthcare in a Post-COVID World, is something I think a lot of folks are thinking about, but certainly my head is definitely remembering that we're in the middle of a pandemic still, and there's so many parts of the world that are suffering. We have a lot of Googlers and Googler families in India in particular, and so that's been weighing heavily on our minds. And we're also thinking a lot about how we can help the community in India, whether that's through some supports through our foundation, but of course, people are going to search and maps and YouTube to get information. And so we've been really in an intense effort to try to help get information about public health measures and where people can get tested and vaccinated. So just as I know that we're going to talk about the future, my mind is very much in the present. And I wonder if that's how your head is right now also.
Yes, I could not agree more. My head has been very much with where we are in the world as a whole, and India in particular. I have a lot of family in India. My father and mother were from different parts of India, met in New York City, where they married, and I was born, and then I was raised in Ohio. But I've been getting WhatsApp messages starting the last few weeks from members of the family, especially in Maharashtra state, where things just exploded. And it was one household, and one person would get infected, and then the entire household would become infected. And then the next, and then the next. Just 2 days ago, I lost a cousin who's my age from COVID. And it's shocking. I have elderly relatives who you would have feared the worst from, and yet they got through. He would not be one of the ones I feared most for, and yet he was the one who died. And that's been the pattern for all of us through COVID. I feel like each wave, starting in Wuhan in China, then Daegu in South Korea, and then in northern part of Italy and Madrid, and then New York and Boston and elsewhere, the waves come through, and it's often hard to predict. India had done so well early on. What is devastating is that it's an example of what we've feared happening in many parts of the world, and what we saw happening in Brazil, which is where the health systems are really fragile. It's just exceptionally dangerous. And, seeing a journalist like we did a week ago, live tweeting their own dropping their own oxygen level on their pulse oximeter, sitting outside a hospital that's too full to accept him until he's recording numbers I've never seen someone survive on a patient and then died. That is just incredibly disturbing. I think the last thing I'll say here is I'm so glad to see the US taking the actions that they now have announced, the Biden administration over this weekend, with immediate actions that involve releasing available vaccine, AstraZeneca vaccine, as soon as they see it's safe. This is vaccine that we weren't going to be using. releasing oxygen capacity, both oxygen concentrators and oxygen generation units that hospitals can use, deploying testing and PPE capacity, and then also supporting the idea that we'll be enabling more than 1 billion more vaccines to be produced. It's a real problem that India has hit so hard because it is the major supplier for the low and middle income world of vaccines, and there's going to be need for much, much more production.
Yeah, first of all, I'm really sorry about your cousin, and you're bringing up this medical manifestation of COVID. It's been such a protean virus in terms of its manifestation, and clinically, though we've learned a lot about treatment, clearly there's still that much more that she has to teach us. And I think the race through the population in India, yes, is an incredibly stark reminder that the virus is not done with the planet. And we're seeing a lot in India, though, of course, as you mentioned, Brazil, but there's other parts of Latin America and sub-Saharan Africa where there is really difficult times for a lot of folks. And I think we have to remember, as you say, that this is a global phenomenon and everybody has to step in. And I too was pleased to see that we were doing our part in the US and other countries stepping up as well, because it's a cliche to say in public health, but no one's safe till everyone is safe. And that's just the fact of the matter. And we have to remember it's not just about our small neighborhood, but we have to take care of everybody.
How do you think about it, Karen, in terms of Google is an international company? And so how do you think about whether it's the US where things got so bad, but then Europe and the globe? What's the responsibilities for the way you think about it for a private sector organization that touches healthcare, but also plays an important part in information flow? How do you think about the division of responsibilities between private and public sectors?
Well, I'd say even more than being a Google person, I'm a public health person, and the way that trained me to see the world was that there's a power in partnership, and that scale and scope of health challenges often is bigger than any one sector alone. A lot of my trial by fire and learning about public health was after Hurricane Katrina, and we learned a lot about how important it was for the business sector and government and medicine to come together to solve challenges. And that's the way that since we've been in this pandemic, we've been thinking about it at Google. And I've only been here for about 1.5 years. I joined in December of 2019. And I came understanding that we had some potential in public health, but it really wasn't until we got into this pandemic in January is when we really started doing messaging on search. We call it SOS alert. So for us, for the inside of the company, of course, we have offices in China that were shut down early. We have offices all over the world. And so our employees were already experiencing the early parts of the pandemic. But as it began to spread across Europe and then come into the US, it became more clear that we were going to have to lean in pretty hard to amplify public health messages. And here's the thing about it is as a public health person, you can build consensus information and put stuff on your website, whether you're CDC or the World Health Organization, but the public has to think to come there. And a lot of the public doesn't know those websites. So what we get to do as Google is when someone searches on search or goes to Maps or goes to YouTube and asks information about COVID, we can point people to those authoritative sources. So we're basically a megaphone for the public health entities all around the world, starting usually with WHO and then localizing to countries. And as the pandemic went on, we got more and more local, so states or counties, and because we know that there was variability in some of the regulations and expectations from public health in those areas. So we see ourselves as an amplifier, basically, of that information, which, as you know, in any kind of a crisis, communication is the most important thing to saving lives. And so we've just been very focused on that component. I think we've also begun to really use our YouTube platform to not only carry message, but messengers, because we have some opportunity to build content. So how do we make sure that in localities, and we're doing a lot of this now in India, how do we make sure that it's trusted, recognizable faces and entities that are carrying the messages, the public health messages that people need to go. And there's a number of other ways that we've leaned in with public health, with academic institutions in public health, and with the medical community. It's just really the theme is that how can we partner? How can we amplify important messages? How can we make sure that data is available to make good decisions? What are the ways that we can try to help facilitate people to get tested, to get vaccinated, to get the information that they need? And yeah.
Can I build on that a little bit?
Yeah.
Just to say, I had some conversations with state officials this week about dealing with, kind of the opposite end of the spectrum here in the US, where testing's falling through the floor because people have gotten such confidence. And yet we still have multiple states where cases are rising, especially related to strains. And then, also vaccination falling through the floor. We climbed past 3 million vaccinations a day, and now it's dropped to 2.5 million, even as we generate 4 million vaccines available to distribute per day. And so one of the striking things was that in many states, there is a mix of the public that is ready to hear the message that there are still things we have to do instead of, simply moving on. And so what's striking is how important for the states the public sector partnerships were. So for example, they'd have county and city public officials who didn't want to hear from the healthcare officials in the same way. And there were certain messages that couldn't easily be carried through through those standard public health channels. And so the links to employers, universities, schools to be able to say, hey, we'd like you to keep testing, or we want to encourage you to get vaccinated and want to push you in environments and in some states where you can't even say those things directly. It's really striking that the first places to come around the public health messages were the employers in the country, and were the universities and schools and academic settings, and it's been the healthcare systems. And those healthcare systems have been really important parts of engaging the public health message in a way that healthcare has not always been directly engaged in public health deployment and public health messaging and in public health solutions the way that I think we all have in this pandemic. So I think I do agree, I couldn't agree with you more that it's how we all come together, and this is playing out in other countries as well. It requires pushing from often the private sector to keep things transparent, to show where the holes in the system are, and to keep driving that forward.
It's it takes an infectious disease, right, to show us that the whole community is connected. It just becomes so apparent that everybody has to be working in concert. It's actually also true for substance use disorder and chronic disease and other health challenges that we face. There are epidemiologic patterns of association, and everybody working together can make a difference. But the heightened awareness, I think, in the U.S. and in other places, that, boy, we can't just say that it's healthcare's responsibility or public health's responsibility, that everybody has to lean in and help. And I think that's part of the sort of go forward lesson learned. There's a lot of lessons learned, and I want to make sure that we cover a few of them in some different areas. But one of them is about sort of how we're going to think going forward about accountability and partnership, and making sure that we're maintaining those relationships, but also recognizing that you're only as strong as your weakest link. And the weakest link, largely because of decades of underfunding, is public health. And I say that with a big heart because I come from public health. I love public health. It stood up. The sector were heroic in everything that they have done and will continue to do to save lives. But they're working, as we say in Louisiana, with two nickels and some friends. Like, they don't have a lot of resources at their disposal, or 21st century tools that can help them have more real-time surveillance. So there's a ton of work we need to do as a country that's in process and being planned, thank goodness, to really make sure that we're strengthening public health. So when it's at the table with the business sector and technology and medicine, that it has the tools and the strength and the resources that it will need to do its part to not only end this pandemic, but to think about all the challenges that we should all be tackling together going forward.
There's an interesting set of things which, and some of it alludes to a question in the chat about how we go forward. And the question was, what elements of public health infrastructure that have been built during COVID should endure and be built upon after we move through this pandemic? And I think you and I spoke a little bit ahead of time, and you said one thing that is completely true. When people start talking about the post-COVID system, they immediately go to telehealth. And that is not what we're going to talk about. That telehealth is
everyone's going to hang up now.
Exactly. That is a tool of moving forward. But understanding what the key lessons are that we are going to use the tools we've got is absolutely crucial. And I'd say there are a couple of things. One is that this has uncovered what has been for a long time something people have pointed to as a underlying weakness of our particular health system and public health infrastructure, which is that we have separate systems and responsibility for the community versus the health of the individual. And when they are separated, you see things like we saw when we suddenly needed PPE and we need ventilators. The healthcare individual systems all had reasons to hoard their PPE and hoard their ventilators and hold on to them, because your responsibility is serve your individuals in your health system, not the community as a whole. And the public health system had no line of sight. They didn't have data on who's got masks, who doesn't have masks, who has gowns, who doesn't have gowns, who has ventilators and who doesn't have ventilators. New York State had to build from scratch a coalition, an alliance across all the health systems to start saying, we're going to bring ventilators, we're going to track where the ventilators are, and then bring the ventilators to where they're in need in New York City. And then, we'll move them around. And everybody gave voluntarily once you said, we're in this together and we've got to do it. But we didn't have that infrastructure. And now we've moved the public health systems away from, and it's taken a year, from faxed lab results and trying to enter by hand, what the results are, to actually setting up the interfaces that allow you to track results in closer to real time. But that's what you do when you only have $50 per person per year for your entire public health infrastructure versus $12,000 per person per year for the acute healthcare system. And so I think one of the key things that people discovered is that there is a relationship between, we all in the healthcare systems got to know our local public health officials and state public health officials. We began working on how do we give you the flow so who's being tested, what the testing capacity is, what the supply capacities are, where vaccinations are going, where they're not going. And that's a ton of work. And then also, suddenly the public health system got a lot more resources, and we don't want to see that snap back to $50 per person per year. I don't know what the number is. It's easily north of $250 per person per year, and having those resources come into place. But I think also public health discovered the healthcare systems and how much they are capable of deploying at large scale. And what they need is planning. They need some notice ahead of time, and they have an enormous capability to reach into communities, serve goals like equity that aren't being met. But they have to be brought to bridge from saying, when we finally launched testing and made it happen, we still didn't have health systems that said, I will be open to all the community and I will make it easy for anybody to walk in and get their test. They were very good at ensuring that people enrolled in their system could get access to a test and get it ordered by a physician in the system, but make it so you don't have to get an order from a physician. That meant states had to set up their own parallel system with, public testing sites, software to enroll people, billing systems, and all of that kind of stuff. And we need to get past that to make our systems much more open and responsible to the community.
A lot of wonderful things in there. I want to grab a couple of threads. One, I think what a lot of people don't know or don't think about is that the public health system in America doesn't have line authority. So the CDC doesn't direct the states, who often don't even direct localities. And that means then that we've seen all this variability in policy and decision-making and availability of resources. And that's the front piece. The back piece, as you describe, is the data is not connected. So just in the way that we get frustrated with a lack of interoperability in the healthcare system, the public health system, it isn't even just that it's not interoperable, it's actually not digitized. And so there's just so much work we've got to do to create at least a coordinated system, if it's not hierarchical. And then that piece of the ecosystem, understanding how it has to work with the healthcare sector, with technology, with the business sector. We saw some great examples of how that worked really well in the pandemic, and I can give examples of how Google and Apple and others have worked with public health. The key thing, though, is that in a crisis is not the time to get to know each other, which it often is the time when it happens, but that now that we know each other across these sectors, we have to keep those bridges built so that we're ready for the next pandemic, which is a question that we have in the chat. Is like, how do we prepare for the next pandemic? And it really, again, is I think going to have to be about making sure we're strengthening the right sectors. You've pointed out lots of important things we need to do to public health, but we also have to keep those relationships strong and make sure that there's some underlying coordinating way and a way for frankly, just the surveillance information to be shared. So we've got better forecasting. And I think that was pretty clear. It wasn't just nowcasting about what's the test results that we have to act on or where's the supply PPE, but going into the future, how are we going to better forecast what's brewing and how we can make sure that we're deploying assets to meet those needs. So that's not the work of individual organizations, honestly, Atul. It's the scale of needing to do this is on scale with, for example, what we had to do with everyone's favorite healthcare program, Meaningful Use, to pour money into the system to digitize public health in the way that we did. We digitized the healthcare sector, make it interoperable, and then find a way that it works with the other systems. But I just want to add one more really important point that you made, and then I want to talk about preventing the next pandemic. We have a lot of good questions that we should get to, but I also want people to make sure they understand something critically important that you shared, which is the healthcare system's inclination, accountability, responsibility structures are set up to take care of their own patients. There are a lot of interstitial communities that don't have a healthcare home. Sometimes they're really marginalized because they're homeless. Sometimes it's because they don't want to be known to the system because they're undocumented. And public health then has the accountability for making sure that they're statutorily responsible for the whole community that lives and learns and works and plays there. And the key, not only is it important to realize that it may take both healthcare and medicine and public health and medicine, but they should work together. But reaching vulnerable and marginalized communities does take not only trust, but extra resources. It is harder sometimes to reach those communities, and you have to work evenings, weekends, be on the streets. So I do want people to remember that that we can't just mobilize the healthcare sector going forward. We have to make sure that public health is partnered to them really tightly. And I thank you for bringing that up because it's a really important part of our future. Okay.
I'll give one example before you jump from that, because this is near and dear to my heart. Before the pandemic, we started with a place where 1/3 of our counties did not have an obstetrician in the United States, and even more did not have inpatient psychiatric capability. So why are we surprised we didn't know whether we had PPE or ventilators, or where we didn't even have a focus on, we're going to make sure that gap is recognized for core services, childbirth, mental health, and that we were going to close those gaps and see it close over time. I think the biggest opportunity for the post-COVID healthcare world is that integration with public health, so that we uncover what are all these gaps and how do we close them. And we have, a biotech revolution coming, and it's going to leave huge swaths behind if it generates massive improvements in lives for people with all kinds of illnesses. We have a sickle cell therapy that is coming out of trials suggesting that the gene therapy is incredibly effective, but it's massively expensive, and this is a community that is entirely African American, and access to good sickle cell care is already a massive problem for that community. Will they get the cure? Will it be provided to them? That's only going to happen if we provide that structure to close these gaps. It really is about the post-COVID world is one in which we are able to continue these links between public health and healthcare delivery to uncover gaps and close them.
So let's talk about equity then, because I think that's really, it's a lot of the thread of what you're saying, inequitable access to healthcare services like OBGYN or to AI, augmented treatments and gene therapies. What do you think? Do you think we're going to have learned our lesson now that we've pulled back the curtain about inequities? Just focusing even on the U.S., much less the rest of the world, but thinking about what the U.S. has seen about inequities and in outcomes, especially for communities of color.
I think we've entered a new place. I don't think we've clearly not solved the issues, but George Floyd brought home the systematic and enduring ways that people of color, especially Black Americans, and have endured unequal treatment in our system, whether it's from policing, whether it's for hiring, whether it's in homes and residencies and in schools, but also in healthcare. And one of the downstream consequences is we moved very quickly to recognizing the vaccines were an example of where there is an unequal system for distribution and treatment for many communities. And it's overwhelming to confront, but we have been. We mentioned CIC Health, which I founded. We've been the kind of support infrastructure for driving out large volume testing and now vaccination. And standing up mass vaccination centers, it started out as words, we are going to serve equity. But then we had to figure out how to do it. And it meant what started out as operating site, the Gillette Stadium site, and then opening in Fenway Park, which is closer to downtown Boston, and then needing to open up a new site in the Black community in Boston, the Reggie Lewis Center, as it's called at Roxbury Community College, and replicate this kind of volume and then partner with FEMA. What we started out with, okay, we got to bring the access, we got to get it closer to people. And then it was, well, we have to have the right messaging, but it really became, who are we hiring? Mm-hmm. Who's doing the vaccination? And then we hired the Black Boston COVID Coalition to go door to door and sign people up to enroll in access to vaccine, and discovered that, we had to change our whole enrollment system. We went to call centers because people didn't have access to mobile phones in the same way and weren't going to fight their way through. And then even the call centers weren't good enough, and we had to move to a totally non-computer-based system or phone-based system at all. We handed out appointment cards, and then we've had to figure out how to make sure you enroll people who don't speak English as their first language and really make people welcome. It took, I had my share of getting stuff wrong and had to be willing to be, criticized and shown that there was a better way of doing things. And that really took a lot for us to learn. We even were changing who we have in our management team and all of that kind of stuff. But it made a huge difference. We now are at a point where in Boston, for the over 65 population, we are at equity. We have, in fact, more people in the Black community vaccinated per capita than in the white community, same in the Asian community. We're still a few points behind on the Hispanic community, with a long way to go in the under 65 population. But you can get to the results, and it takes this level of thinking. We're not going to have forgotten this thinking and these lessons. It will still take a lot of unpacking and work to do.
I hope so. I'm very hopeful that this won't be a fad, and that it will as someone said to me yesterday, it won't be a moment, it will be a movement. To get there, of course, we have to, it's pretty clear to me that this next generation, the future of healthcare is going to involve more accountability for the system around equity and creating an anti-racist system and having an inclusive lens in all the work that it's done in the way that you're describing, but also really thinking through every policy and approach that the system takes. And healthcare in general, it seems to be rallying around that idea. You're seeing some big systems like Intermountain or big health plans like Humana come out with important statements about equity and processes that they're going to take going forward from the lessons that they've learned. But I'm still waiting to see if it's going to be, if we're going to make it real that we want to eliminate inequities just as we want to raise the floor. But everything you're describing too, by the way, is just public health practice and approach. It's that it's the way public health does its work of iterative with community, not for community, with humility, bringing trusted messengers. And so I think the more that the two Siren sisters, Hygeia, which is public health, and Panacea, which is medicine, come back together and learn from each other and help build strength. I think that's going to look more like our future is this kind of better coordination and learning from best skills. We have a bunch of questions, or not a bunch, a few about workforce, which and some of what we were just talking about gets into having people on the team who have lived experiences like those that you really are trying to reach. And it also, I think there are a lot of people who are really exhausted in the healthcare environment. And I'll say I'll speak to public health, and maybe you can take the medicine piece. We're losing a lot of public health talent in the pandemic. A lot of people stepped out of their leadership roles. Their lives were being threatened. Their families were being threatened. It was exhausting, and they had few resources to work from. And I think they just sort of reached a point where they just decided to step away. There were many reasons, but many of us in public health have been very concerned already about losing talent from senior public health, and we lost a lot during the pandemic. On the good, what we're seeing is a huge uptick in applications to schools of public health, and a lot of excitement about that field, and a lot of infusion of resources that you mentioned earlier in the U.S. context to build workforce capacity in health departments at the federal, state, and local level. So I'm sorry that we lost some of that talent, and I hope we don't continue to. I'm very optimistic about the fact that there's renewed interest in public health as an important profession, as a critical part of the country, and then this investment to see that we can not only have more talent, but help that talent have some of the tools that it needs, sort of 21st century kinds of tools, whether that's digital and IT work. So I think we're on a good upswing. That's what I'll take for public health. What do you think for medicine?
Yeah, it's parallel but different in certain ways. For one, in public health versus medicine, people in medicine were hailed as the heroes, and I actually think we have not hailed enough of those local city and county officials who they saved many, many lives and took enormous heat and were kind of greeted with a lot of hate in a way that medicine never faced. And yes, I'm thrilled to see that nonetheless, we have a lot of young people saying, this is the field I want to go into. I can see the difference it made. Healthcare, the medical professions have seen a massive uptick as well. I am very glad I'm not applying to medical school right now. Maybe it's like threefold the number of applications have been coming in compared to when I was applying to medical school. And I think that's very exciting for the future of where we are. What's really also been hard, though, is there are lots of patterns indicating that the same phenomena that happened of the big getting bigger in the retail and other non-healthcare parts of the economy has been happening in the healthcare parts of the economy. Independent physician practices have not had a lot of reserves, and you take 3 months where patients stopped coming in, and you had a lot of physicians have to they had nothing to fall back on except to join up with large systems. And so you've seen a number of mergers and sales into either big healthcare systems or Optum and private equity-based ventures, where my concern is that the focus will be diluted on especially strengthening primary care and changing models of care that give more responsibility to primary care to help achieve better community outcomes as well as better individual outcomes, and a better outcome per dollar for what we're doing. And so I am concerned about where primary healthcare emerges in this, and then rural healthcare emerges. A lot of rural capacity has gone away because that has been, marginal. You've had closure of the smaller hospitals. Things I am excited about and interested in is that it didn't get a lot of attention, but last fall, Medicare did approve, before the Trump administration left, that hospital at home care would be reimbursed at the same level that hospital care as a formal inpatient is reimbursed. And so you had a jump from about 9 systems that had been doing, small pioneering work establishing hospital at home, my system at the Brigham Women's Hospital being one of them, to one where in the last 3 months you have over 100 health systems that have been certified to move ahead with hospital at home programs. And that really, I said we wouldn't talk about telehealth, but
we will.
That capacity to enable our infrastructure to reach much further beyond our walls, I think is especially these kinds of services that are closing in these communities, is going to be super important for both mental health and for some of the hospital programs. And I'm hopeful that after the emergency ends, that those programs will be continued. All of them have been done under, as emergency provisions. I think there's lots of reason why they will demonstrate value, they'll demonstrate safety, and they will be continued.
I'm a big fan of home visits. I did a lot of them when I was practicing primary care. You always learn from context. So, and related to that is this idea of how much could we be doing if we were really going to meet people where they are, especially when they've got an environment where they could stay home. And we had at our VA in New Orleans a hospital at home program even before Hurricane Katrina, so 2005. Meaning it's a tried and true approach, even when you don't have super sophisticated technology. But people want to do that kind of, there are people who would prefer to stay home if it can be done safely. And I think the pandemic in many ways accelerated the sort of roadmap for a lot of products. We say that a lot at Google. There were things that we were thinking about doing, like making sure that people could find telehealth as an option for care near me when they search on that. So now we've got that as an option because it became such an important, frankly, life-saving treatment for a lot of folks. It just accelerated the work. And you're seeing this in the pandemic also with hospital at home. Yes, it was approved. And so there's a regulatory and a payment pathway, but there's also now this not only a will, but a way. We've learned that telehealth or hospital at home or care that doesn't require a person to take off work, to take a couple of buses, to have to think about getting childcare or parent care, or that we can actually come to them and do that in not only with telehealth for chronic disease visit or an acute visit, but as you're describing for hospital at home. And so if you can't tell, I'm really excited about it because I think where it matters, I think where hospital, if you have to admit to the hospital, it's almost a complete failure of the system, right? And certainly as in pediatrics, so the more we can do to try to, where appropriate, make sure people can stay in community, they tend to there are reasons why they might do better. So I think the future, if we're going to be back to the topic, is going to be more about that, like really meeting people where they are instead of causing people to come to our bricks and mortar during the office hours that work for us. Now we have to figure out equity. We've got to figure out how to get broadband, cell coverage, smartphones, video capabilities, how to handle communications for people who are sight impaired, hearing impaired, have cognitive impairment. The list is quite Thick, though not insurmountable. And of course, it's not a complete supplantation of care. What we know is that telehealth and digital services are probably an augmentation to the art and humanity of medicine and the in-person piece. But I don't really see us. We slowed down, frankly, more than I thought we would in some of the digital capabilities. But I certainly hope that we continue to remember that a big part of this is I'm going to use the word convenience, even though it sounds too light, but it matters. And if you've got to take off work to come to the doctor and you're paid by the hour.
Well, I think this last point is really important. If the way we're building virtualization of care is there's a virtual channel and you get some services through it, and there's a in-person channel, you get different services through it, this thing just falls apart. What has made the hospital at home program that we've been involved in at the Brigham and Ariadne Labs, which I'd founded, work is that it's just agnostic to whether you need in-person care or not. It's just giving you the right care in the right channel in the right way, and it can move seamlessly among them. You know, being able to get you at home, you have enough monitoring in place. A nurse can see you in person, a nurse can see you virtually, a doctor can see you in person, a doctor can see you virtually, a paramedic can see you. There's a range of people on the team, and there isn't a situation like you have with a lot of telehealth programs where, you know, I have a light urgent care capability, but the minute I need to get a lab test or have somebody see you and feel what your, you know, abdominal pain is like, oh, well, we don't do that. And you get sent somewhere else. It's that, and that's why I think the payment structure has been so important, because it made the system much more indifferent to which channel you're in. Are you virtual? Are you not? And instead just made sure you're in the right channel, and that the care is appropriate, and we could move between those channels as seamlessly as possible. That's the totally crucial design component. It is making sure that the incentives and the structures have a coherent system for the person that can reach them all the way into their home.
Which is a good segue into a few questions we have in here about the money. So sort of it's the how and what are the tools that we could deploy to give people better continuity, to be more truly person-centered, community-centered. But yeah, how do we pay for it? And the questions are things like, does the pandemic move us more towards a single payer system? What are the ways that we should be thinking about paying for care in the future that would enable us to keep some of the good parts, if you will, of digital health? Do you think it's going to push us towards universal coverage?
Well, what's your take first?
Okay, so for me, I always think of it in two buckets. The one bucket is what's the bank account, and the other is how does the money move from the bank account to the delivery system, assuming that we're not going to be all under one umbrella like a VA, which is the money and the transfer of dollars goes to the delivery system all under one roof. I suspect in the future it'll always be a delivery system that's largely distinct from the financing system. But the money has to transfer. And so I think the thing that we learned a little bit about in the pandemic, we've learned about in other crises though, is that when people are in a system of care that's accountable for their total health and total cost, that allows for a lot of flexibility in how they reach people. So in other words, if you're not getting paid by the piece or by the visit, but it's rather, is somebody going to stay out of the hospital or stay healthy or not develop diabetes across the year, then you see those kinds of primary care systems or bigger systems deploy community health workers or digital technology or group visits or all kinds of innovations to try to meet the needs and expectations of the population. So that certainly was in the Obama and parts of the Trump administration, a movement towards value-based care, though not in the sense of a quality indicator, really in the sense of global budget. So I think when we continue to look at how the performance of systems with respect to good outcomes for people, we're going to learn some things about whether being in a global budgeted system as a patient means that you had more differential access to the kinds of supports and services like telehealth, et cetera, more quickly than if you were in a more traditional fee for service system. And then we may continue that movement towards global. I can tell you this, I mean, at least in the Medicare program, what we see is that over the course of years, consumers are making the choice to move towards MA, which is more of a global budget program. And so for whatever reason, more and more Medicare beneficiaries are like that kind of relationship, basically, with the system where it offers them more amenities, more tools that can address the social determinants of health. So I'll take that part. You take the financing part.
Yeah, I'll build off it to say, I think the pandemic has only accelerated a process that's just continuing to demonstrate that the fundamental flaw of our healthcare system is we've financed it through employers, that where you get your healthcare insurance is through your employer. And at a time when people are moving in and out of employers even faster than ever, it has made for a very problematic system from a medical point of view, because we are now taking on and building capabilities that will solve problems now, require investments now for the sake of outcomes that will change your life in 10, 20, 50 years. What am I talking about? I mean, hepatitis C cure, we have 3 cures for hepatitis C now. And the main headlines were about how expensive it was. When you have an investment in year 1 that will save 10 times that much money in the next 10 to 20 years because you've avoided someone going into liver failure over the course of their life. And the reason it was that kind of focus was because an employer doesn't want to make that payment in this moment in time because they don't see the benefit from the employee who will leave and have that extra improved life 10 years from now. Genomics, our ability to really forecast your most important needs going into the future 10, 20, 30 years means investments now again for further down the line. And I think all of those things push towards breaking the link between where you get your healthcare and where you work. I think there's the challenge then is, does that mean that it's payroll tax based with a single income based that way? And how do you transition to there? I'm struck in it, we're still a ways away from the politics of it, but the transition that's possible by lowering the Medicare age to 55 to 50 means a couple of things. Number one is now you're getting the more of the sicker cohort into programs that can stick with them across the course of their lives, not change their medicines every time they move out of employment or have a break in their employment, not change their doctors, et cetera. But it also means that for hiring people, you aren't putting as much expense on the employers. The people over 50 are the ones that are the highest cost, highest need patients, and that would have a dramatic effect on bottom lines for organizations, and not penalize those that hire people late in their career. And so all of those things, I think, are I think we're in a necessary world of continuing to break that link and make it possible for people to move seamlessly in and out of their job environments while having good coverage along the way. Now, politically, with a 50-50 Senate, the votes for for even getting that sort of reform pathway through that Biden had endorsed is very tight. It's hard to see how that comes together right now. I think the midterm elections are going to be crucial for our ability to do more than shore up the existing ACA, the existing Obamacare system, although there are important things to do there still.
It's about a continuity of relationship with your means of financing with your insurance partner, and just like you would want to have with really good primary care. I think we have about 7 minutes left, and there's a question very particular to you and one more particular to me that we should maybe get to, because I think we've covered some others of this, but one of them that tag, there's a third question which tags on to what we were just talking about, which we didn't address, and that is there another place in the world, a non-US example, where the pandemic worked well, meaning I should say the tackling of the pandemic worked well, and is there something to learn from that? Does it have to do with single payer? Does it have to do with the structure of their public health system? Have you done much work on that yet?
Well, it's always difficult to make a prediction now that there's a place that's done well, because this pandemic continues to rage. But the one part of the world that, you can divide the world into the places that started off well and continue to do well. There are ones that start off well and then crashed and burned. You have places that, like the US, that really started off really poorly and were starting to do well. But the ones who started and finished there have been places like Australia and New Zealand. And I think the pattern, whenever the systems have started to really do well, is that you have had clear, consistent alignment between public health communications and the political communications, and that you have a cohesiveness in those messages, which has allowed people in Australia and New Zealand to come together and have very, very strict early on lockdowns, and then strong testing programs, and now vaccine programs moving through. And if they're not hit by the strains, the new strains in ways that cause explosions there, they have a good shot at emerging from this, having had a strong a country in strong shape without a lot of deaths and effective policies that have carried them all the way through. But it does require that cohesive execution at every phase of this along the way.
There's a book called Who's in Charge, about public health communication and messaging. And I think New Zealand is the textbook example of how having a single clear messenger that everyone trusts, their prime minister, who is the voice and the face who brings the science forward. And it's not a cacophony of voices that are confusing to the public. That's but one example of, I think, how they've done well.
And I can point also to Vietnam and Thailand and other places like that have really done the same thing. And they're, executing well on vaccines so far. Still a finish line to get to, and parts of Asia are, of course, exploding. So
yeah, no doubt about it. I'm going to take my question and then let you have the last word. I think there's some questions in here about AI and Google and whatnot, and I think maybe the way to describe it is we of course are working on AI as an augmentation to how to support the healthcare environment, not only in the U.S. but globally. The work that we've been doing in earnest with partners in all over the world, India, Thailand, the UK, the US, has a lot to do in the space of imaging and diagnostics, which you would think would make sense because ML works well in that kind of a pixel environment, and where you can have images, especially from radiology, whether it's mammography or CT scans, or in retinal scans, retinal images, and then some work in pathology. We're partnered to understand if we can not supplant, but rather be a part of the workflow to help. For example, in our work in diabetic retinopathy with Thailand and India, is to see if we can help float the high-risk cases to the top of the pile and get those referred into this scarce resource, which is the specialists. Because right now there's not really a system to sort the retinal images. The work we're doing with the National Health Service in the UK is to shorten the timeline to a woman getting the results of her mammogram, because they require a second read, and from two radiologists. So we're working with the NHS to understand if AI can be a second read, and then if there needs to be, if the read between AI and the radiologist differ, then there can be a human as the third read. So our approach is that it's an augmentation to the clinicians, that there are spaces where it seems that it can be a part of the workflow and address issues of scarcity of specialists or supplies, but also help to improve the patient experience by shortening time to getting a particular diagnosis. So, and accuracy, I guess I should mention that, especially we've published some work in areas like pathology, where obviously the AI is quite good at finding that cancer that maybe the human eye can't always see. So I think there's a lot of promise in AI. I guess that's why I'm at Google. Though I think there's an awful lot that we still have to work out, and I don't see a near future where it's replacing humans. That we want to do everything we can to try to make an augmentation. All right, your question. You have a lot of questions in here, but I'm interested in this one about, since the publication of Being Mortal, where you see any changes in thinking about end of life care, and I think coming on the heels of this pandemic, where we've all experienced suffering and death, and I think have you been seeing or hearing ways that maybe that's changing people's perspectives about end of life?
Well, I think a couple of things. One thing I worry is that we lost ground. The core element that I really found in the work I did interviewing people about care towards the end of life, and then it really emerged like care in any situation where you have a serious illness, is that people have goals in their life besides just surviving and living longer. Those goals for the priorities for their life and for their care can change over time and are different from person to person. So you have to ask people what their priorities are, what they're willing to go through, what they're not willing to go through for the sake of more time, what their fears and hopes are if their health should worsen, and how we can best achieve the goals they set. You have to have those conversations, and we don't have those conversations. We have them less than a quarter of the time. And then when we said, we have to lock down because of the pandemic, we don't even know how this thing is spreading, we suddenly locked away some of our most disabled and elderly and frail people. And it took us way too long to say, we're gonna make sure family can get in if that's their priority. We're going to suit them up. We're going to use scarce PPE to give people that access. And we just didn't do it. And we didn't do it for way too long as an indication of our not prioritizing what really matters to people. We left too many people really suffering in solitary confinement. I think we have recovered some of the perspective that we need there. And I think we have a long way to go. I think we've moved from a place where it's not considered death panels anymore to ask people, what's the minimum quality of life you'd find acceptable? How do we, what does that indicate about what we should be willing to do, what we should not be willing to do for your sake, or how we tune your care to meet your goals? It's now sort of like mom and apple pie, but it's not yet a scandal that we don't ask and sort that out. 3/4 of the time, we are not addressing those issues, and those people have worse outcomes of care and worse experiences of care as well. So we have ways to go.
So you would say the future of healthcare post-COVID is about partnership and about prioritizing humanity.
I would buy that.
All right. Atul, it's really great to see you. Great to chat. Thanks everybody for joining us. Really appreciate it.
Great to see you, Karen, and thank you, everybody.